I've got this. Okay. Good morning. So, first of all, thanks. I just want to say what truly an honor it is to be here. And just so you know that I'm not just paying lip service, I'm wearing a tie. This is not something I do very often at all, like ever, like maybe since my wedding. So, but, Lorimer put up this thing yesterday about, the research behind the tie. And then Jason comes up and says, if we're going to cross the chasm, that we got to start integrating the research. So, whatever, I'm wearing a tie, okay? Okay. So, but truly, an honor to be here. Rajam, wherever you are, respect, thank you. So I'm going to talk today a bit about these novel movement opportunities and these movements that I've done that I call Edgework. Okay, and kind of in keeping with the terms of the conference here, this is meant to be some things to kind of help demonstrate the ways that I've tried to take some of this information and make it applicable to the clinic, right, which is kind of the whole idea of the course. So, and what hopefully we're doing, right, is accomplishing some of these things without violating some of the things that we know about pain and about the importance of movement. And the effects of medicalization, this is a big one that I'm interested in, iatrogenic effects of care. So we're going to get into this pretty quick. So I think first we got to lay the groundwork. We need some operational principles. These are the things that are the foundation of what we're about to talk about. So the first is this idea that pain is an opinion. Pain as an opinion, right? Dr. Ramachandran, San Diego guy, right? And did I hear he might be next year on this thing? Awesome. Dr. Ramachandran, yeah. So he said pain could be considered an opinion of the organism's state of health, right? And so I really like this, the OK scale. So this is, John talked about homeostasis in his last talk. The OK scale, things are at baseline as far as homeostasis. This is the perception of the body's state of health, state of being. OK in the middle, we're in the baseline. The perception is things are not going so great, not homeostatic. OK minus, things are heading in the direction that we want. OK plus. And you Simpsons fans in the audience, you remember Homer's invention, the everything's OK alarm? It only went off when everything was okay, But so we want things moving in the direction of OK plus, right? We want things moving in that direction. And what I'm going to try to talk about is that these things have narrative associations, behavioral associations. When things are moving in the direction from OK minus to OK plus or any other direction, these are associated with things that are in our narrative and in our behavior. And we want things moving in that direction in the direction of OK to OK plus. Okay? Okay. Second is this idea of context architecture. Okay? Quintner and Cohen did an article or a paper where they talk about pain as an aporia. What that is it's a space that we cannot access in another, right? And Dr. Mosley alluded to this when he talked about pain as the hard problem of consciousness, right? Qualia also is what this is talked about. We can't access another person's pain necessarily. We can throw up functional MRIs of what a person's brain is doing and what areas are lighting up when they are thinking about red, but that does not tell us about the redness of red, right? So we cannot access this. It's a subjective space that we own and we cannot share, unfortunately. So where I think that this comes into play for us, we also bring our own subjective space to the table when we are treating people. And then the third space is the table itself, the place, the environment that we're treating in, that we are interacting. It's that interactive space. And the things that we can change as therapists is what we bring to the table ourselves and the table, right? The environment that we are treating people in. We are architects of the context of the interaction, or we can be, for good or for bad, right? So along with that is this idea of novelty. So if pain is an opinion, why might novelty be important? Something new, something novel, by definition, is something that we don't yet have an opinion of, right? So I view it as an opportunity a blank slate where maybe we can introduce something and alter that opinion or change that opinion or even get on a new track where a new opinion is got. But it can't just be novel. It can't just be something new that is meaningless. It needs to be in context, right? Okay? So we don't just want novel. We want novel in the context of being disarming. We want things moving in the direction of okay on the okay scale. Right? That's the context. And think of it this way, if you want to think of some simple terms to take away from this. Context is everything. If you change the context, you change the story. And people are operating under a story, right? This is the story of our being. You change the context, you change the story. If you change the story, you change the outcome, right? Who would have known that Back to the Future told us everything we needed to know, right? That's the story of Back to the Future. Okay, so excuse me. The next operational principle is this thought of looking at things as opportunities versus dysfunctions. And, this is nice. Everybody's already talked about this stuff. I could just move ahead with, let's just tell stories instead. Everybody's like giving my presentation. But, okay, opportunities versus dysfunctions. So when we are assessing people, so let's say we've already ruled out red flags, things that we might need to refer on or whatever, and now we're looking for some direction of what we're going to actually do with this person. Most approaches and methods and things that we've learned will approach this from dysfunctional terms, right? I mean, all these methods have dysfunctional labels along with them, right? I mean, a stuck this or that, an inflexibility, a muscle imbalance, these things. So think about, if you are the patient, what do those terms do to you if you hear that you've got an upslip or an imbalance or an unlevel this or that? How does that impact you on the okay scale? Like, oh my God, I've got a what? That's bad, right? So versus, if we start viewing these things that we see as opportunities, because we know that people have all these things in normal life, right? I mean, all of us have asymmetries. It's a normal thing. Whether you have pain or not, you've got these little findings. We all have our little tendencies of movement. So what I suggest is that we flip the script and we start talking about these things as opportunities for change. Okay, and again, think about that okay scale. How's that going to impact, if you talk about like, ooh, you've got this problem and this problem and this problem, versus, oh, well, look here, we've got opportunity to change this. You move a little differently here than you do there. This is probably changeable. We can probably change the way you move here pretty easily, pretty quickly. You change the narrative from one of dysfunction to one of opportunity. Okay, next is the narrative progression. I talked about the OK scale has its associated narratives. We also want not only that OK scale narrative, we also want a narrative of self-efficacy. Right, so Costa and Maher and all at 2011 had this nice study where they were comparing, what they were doing was comparing self-efficacy versus the fear avoidance belief approach. And what they found was that self-efficacy mediated both pain and disability at the onset, and it mediated change in self-efficacy, mediated the change in pain and disability over, I believe it was a 6-month or maybe it was a 12-month period, I can't remember. But self-efficacy mediated these things. Also important, self-efficacy is something that is modifiable. Right? So we not only want people to be moving up the OK scale of feeling like homeostasis is moving in this direction of improvement, we also want them to feel that they have gotten there under their own accord. Right? We want to build self-efficacy. Right? In other words, you could take somebody up that OK scale, but if it is viewed to be a result of something magical that we've done with our hands, the next time they encounter a problem, I got to go back to that guy with the magical hands, which, as John alluded to as well, that might be good for business, but it's probably not in the best interest of our patients if we can get them to do it under their own accord. So we want progression in the narrative of self-efficacy. So self-efficacy has its own kind of narrative associations and behavioral associations: taking control, self-advocacy, confidence, adherence. These are the things that we want to look for in the narrative and the behaviors of the people that we're seeing. This is the type of thing that we want to watch for. indications of an increasing self-efficacy. Okay, and then the last operational principle is this idea of change at the edge. Okay, the edge denotes a place that you approach and a change is required. You can't move forward anymore without something different happening. This is why I like to consider this the edge. And Dr. Mosley at one point said, pain is that point where the body's considering the question, how dangerous is this really? Right? And I like this sign because caution chart. I mean, the children, how dangerous could they be? How dangerous is this really? But, you know. So, but the nice thing about the edge is because it is engaging that process, we will hopefully be able to see change quickly and see subtle changes. It's also a place that's ripe for change. So we can work at the edge and hopefully see changes, have changes happen more quickly, or we can come back and recheck the edge as a place for test, retest, and things like this. Okay, the edge is the place where subtle change gets noticed. So the overall goal, what we're going to try to do, we want to teach interactions with the body, or we want to teach people to have interactions with their body and their surroundings that are conducive to the natural course history. John put this up as well, the withdrawal, resolution, progression, and preserve, build, or even establish, in some cases, self-efficacy. We want to be doing both things at the same time. Okay, so that's our goal. Okay, so with that in mind, I'd like to actually walk through some of this stuff. Can I get a willing volunteer up here? Anybody? Sure. Yeah, so if I could just have you lay down on your back. Yeah, either way is fine. Actually, I'll put this under your head. Okay. Great, and actually, could we maybe get this podium down now? Would that be a problem? So we're going to walk through a couple things here, and please let me know if you're having trouble seeing this. We're going to move the podium down. But so I'm going to walk through a couple of simple things, and this is stuff that I use all the time in the clinic. But what I like about this is it has the potential to be a very experiential way to explain pain as well. So let me have you bend both of your knees up. So the first thing we want to do is set a baseline, right? So let's say in this case the baseline is back pain, hurts to bend over, hurts to squat, things that we see all the time. And then once we have that relevant motion, something that we can check, recheck, the next thing is to establish this idea of the edge. And so one thing I'll have a lot of people do in this case, let me have you bring your feet together just a little bit. Okay, good. And I'll say what I'm going to have you do is you're just going to move your knees side to side like windshield wipers, right? Good. But before you do that, come on up here. What I want you to look for is I want you to just go nice and easy side to side. You're not pushing this, okay? And as you reach either side, you might find when you get to one direction or another, there's a change, right? And what we're looking for is whatever indicates the beginning of that process of change. And I'll leave it pretty general because it is in their realm, right? I'll say whatever you feel like is the beginning of that kind of protective stuff that comes along with this. It might be a change in your breathing pattern. You might notice a change in the tension in your muscles somewhere. It might even just be associated with a feeling of unease, right? It could be a lot of different things. It may be pain, but pain is not necessarily the best guide on this type of thing, right? Pain could be or could not be associated with emotion. So that could be a good edge marker, or sometimes it's not. It's kind of a difficult one to use. So, but at the beginning, when you're trying to get somebody there, you might use that one because you're trying to kind of reach them at their point, kind of reach them where they're at. So anyway, let's just say in your case, you can go about halfway out. Let's pretend, okay, right? And you're finding that spot. And here I'm just trying to help them practice kind of understanding where that's at, right? Give them a chance to feel it, okay? So then, once we've got that established, then I'll have them do exactly what he's doing here. I want you to, now that you know where that edge is and what it feels like, I want you to find it each time, because it might change. What we're hoping for, what we're looking for, is that hopefully that narrative change that we're looking for is one of expansion, right? So hopefully as they move, they're seeing that edge move a little bit further out, right? They are having the chance to engage that process under control, which in and of itself can be disarming in some people. And I call this nudging. I tell them they're just trying to nudge up against that edge. You're not pushing through it. You're not plowing through it, right? You just want to find right the beginning of the edge. And a quick story, I'll try to throw out a few stories that I like to tell patients here too that might help. I'll say, like imagine you're in a dark room and you want to get out, but you can't see anything. You want to find the door. Would it make sense to just shut your eyes and run as hard as you can, to try to get through the wall? No, right? But at the same time, if you just sit in the middle of the room in the chair, you're also not going to find the room. What would make sense would be to explore carefully, slowly, so that you can find an edge, and then you can walk away or walk your way towards a direction to eventually find the door. That's kind of what this is like. We're exploring that edge so we can try to find our way out. Okay? Now, so that is nudging, and I also have, got to remember to progress the slides here now. Oh, I'm going the wrong direction. There we go. Okay, yeah. Oh, isn't that cute? Man, I feel like I've just posted a cat picture on Facebook or something. Right? So, but I call it nudging. The other one is, I call it scraping the barrel. This is kind of the same idea, except more you're kind of working along the edge instead of going up and away from it. And hopefully we'll get to this too. Okay. Now, the next one I say, looking for opportunities for novelty. So, can I have you switch over so that you're on your hands and knees? Okay. So we might see patterns in the way that a person moves. They might have certain tendencies. I think a really common one is to see people who move really easily through their backs and not so easily through their hips, which, whatever. Again, I don't tell people that that's a problem. I just say that's just how you tend to move. Cool, that's fine. But let's see if we can figure out some ways to move in some other places. So from here, let me just have you rock back. So I want you to just kind of keep your belly sagged, and you're just going to sink back into your hips. Okay, good. Hip flexion, right? Okay, and then come on back up again. So I'm just teaching them to move from somewhere other than the place that they associate with their pain. And what we're again looking for is narratives of expansion. They're learning to move in new ways. Their movement repertoire is hopefully expanding in a somewhat relevant motion. Most of the things we do with our back, we also do with our hips. Okay? And so that's good. Thank you. And so, and you can go ahead and lay back down on your back again, please. Another thing I hope you take away from this, you're gonna, you might see some of these things and be like, if you do the movement impairment syndromes, you'd be like, oh, I recognize that, but he's doing it wrong. Yeah, so I am. But you're doing a lot of this stuff already. Is one of the points I'm trying to make. This is not some magic handshake technique or method. This is just a way to think about some things that you probably are already doing. Easy for me to say that you are already doing. Okay, it's just a way of framing the way that you do them. Okay, these are some examples of the way that I do it. You probably have your own ways of doing things already. Maybe after some of these talks that you're going to get this weekend, you're going to be able to throw away some stuff that you don't necessarily need anymore, but there's not necessarily, doesn't have to be my way of doing this. This is just something to overlay with maybe what you're already doing. Okay, so that is finding an opportunity somewhere else. Again, it's novel. The idea is that hopefully this is a novel movement. It doesn't have to be something they've never done before. Most of us have flexed our hips. Think of it more as, I've never thought about using it this way before. I've never thought about moving from my hips when I move my back. We're just trying to do something different and hopefully doing it in a disarming way. Okay, so the next one, I call this stacking the deck. And again, you don't have to use these terms. It's just what I call it. But I call it this because we're cheating. Basically, we're trying to add something to this movement that already has associated with it something that's in that narrative of progression that we're looking for. Okay, so let's say when you do the side to side with the knees, go ahead and do that. Let's say one side is like, whoa, no problem, and it comes to this side, it's like, I'm not so sure about that. We tried nudging, and it's like, yeah, it's not really making much of a difference. So what we can do, I'm going to say, okay, find the edge, again, to this side, but I want you to stop there. And once you get there, I want you to take 3 great big diaphragmatic breaths. Why 3? I don't know. Why not? So, but the idea here is that when they're in pain, right, we've got fight or flight response typically happening, which tends to change our breathing pattern, tends to change the way we hold tension through our muscles. Lots of things associated with that. One of the voluntary things that we can control with that is our breathing pattern. So diaphragmatic breathing tends to oppose the fight or flight motion pattern. And so, again, we are trying to associate something that is going up that OK scale with something that the opinion is not so sure of yet. So what I'll do is I'll have them do the 3 breaths, come back to the starting point, okay, and then now find the edge again. And then, yeah. Whoa! Yeah. But a lot of times, so usually when I do this, actually, I'm standing back here and I'm telling them, okay, just kind of look through your knees and see where you're getting, because really commonly you'll see they're going to get like, whoa, ton more motion all of a sudden, all right? It's become a more disarming, the context has become more disarming, and the result is an expanded amount of movement available to them, which, again, I tie this into the narrative that's involved, right? So another one, let's come to the same edge again this way. Another one you can do is I'm going to have you push back into me just really lightly, not a whole lot, and you're going to say, hey, that's contract, relax, but you're doing it wrong. Yeah. Okay, and then now relax, okay? And then I'm not pushing, I'm just kind of keeping my hands there. A loss of tension, a reduction of tension, is something that is commonly associated with an expansion of movement, right? Things that hurt, a lot of times we create tension with it. So helping them, I consider this like an exaggeration, right? Sometimes an exaggeration makes something more obvious. And so giving a little bit of a push into the non-threatening direction and then letting go makes that effect a little bit more obvious. It's the same as an exaggeration. Okay. Good. So basically the way you work this is you teach them where the edge is, you work up to it, you make a change, and then you look for the edge again. Test, retest, essence of science, right? And when the edge changes, you take up the slack and you work from the new edge. Rinse, repeat, progress, right? Okay, so let me have you sit up on the side now. So after I've shown them this hip sync motion, I might then show them how that they can apply this to a sit to stand. It's a little tough from this, but let me have you just kind of scoot out so your feet are on the floor. And I'll say, okay, just like we did here, I'm going to have you kind of lean forward, but kind of stick your chest out. And I'm not saying, gauge your core and all this type of stuff, right? Because like, oh my God, there's something wrong with my core. Again, we're looking for opportunities, not dysfunctions, right? But a lot of times people, when they do this, all of a sudden, it's much more comfortable to stand up. And I'm not saying, okay, from now on, this is how you move. This is the right way to stand up, right? I'm just saying, this is more comfortable for you right now. This is hopefully going to help you do a movement that was uncomfortable before, long enough to get out of its way so this thing can run its course. Because most of the time we are working with things that have a natural course history, right? And so that's what I'm trying to convey to these folks is that if we can just change the context enough that we can kind of move the narrative along, get out of its way long enough that natural course history can take effect, and they've walked away with some ways that they know how to control it. So now hopefully at this point, he knows that he can engage that edge with control by himself. He has confidence that he knows something that he can do, something he can move up to that point and know that he's safe. And adherence. This is something that he can apply to movements throughout his life. These are all things that expand that self-efficacy narrative, right? So that is what we're looking for. Okay. How are we doing on time here? Okay. So I'm gonna walk through a few other ones here. Okay, so let's say, the first step, set a baseline, right? So we want to know what is the movement of relevance here. So let's say you've come in with knee pain. Okay, it hurts to go downstairs and it hurts to squat. Pretty common, right? So let me have you lay down on your side, facing the crowd here with your head at this direction. I'm going to kind of skip the nudging and some of that stuff, and I'm going to move on to another one here. So this is another motion that I'll have people do a lot of times. I'll say, okay, let me have you raise this knee. Keep your feet together and raise this knee up. Okay, good. I'm working with a therapist here. He already did this. But what do most of our patients do when they do this? Like, they do this, right? Cool. I mean, most people do this. But I'll say, okay, that's fine. And, one thing that we see a lot of times people who have knee pain is that they have tendencies, right? They might sit with their knees together and they might squat and their knees might kind of travel inward, which, again, I don't be like, whoa, that's a problem. I just more say that's a tendency that you have to move, and this is one that a lot of people have. And in some people, it might be so strong that it's almost like they've forgotten how to move any other way. Right? And I say, that's fine. You've lived your life like this up to this point, and it's not given any trouble. But when your pain is associated with motions that go in that direction, and you don't know how to move any other way, it's like you don't know how to move any other way than a way that's kind of constantly reminding you that this thing is sore. Right? So when that's the case, again, novelty, I'm looking for, let's move in the opposite direction. So here I'll teach them, let's keep the hips still and move the knee up and down, right? And the other nice thing about this is that we've got some research that this kind of movement is helpful for knee pain, right? And strengthening of the lateral hip, good for knee pain, right? So one way I will frame that is I will say, okay, there's some things that we know when we have pain. It changes some things in us, changes some of our muscle patterns, and we know that in certain cases, the firing of the lateral hip changes in people with knee pain. Okay, so strengthening is out there as something that we've got some research behind. But what if we also framed it as this is something, this loss of muscle activation in the hip is something that tends to be associated with knee pain because the two things happen together for whatever reason. What if we do a motion that you've got no choice but to try to kick in this lateral hip muscle group, right? Now, it has become a motion that is happening in a way that's more consistent with the OK on the OK scale. It's happening when we are not moving under duress, right? And hopefully this becomes a novel movement in a disarming way. The other thing, too, with strengthening, I might be jumping ahead a little bit on this, but I kind of view strengthening as it's kind of a built-in progression that has some of these things already going for it. You know, you're starting at a baseline. It's got a built-in gradual progression. Tends to be a bit meticulous in the way it progresses, so it's got kind of built-in persistent. These are all narratives that are consistent with self-efficacy, and it's something that people tend to do themselves, right? So, might it be the gain in strength? Sure. But might it also be a change in some of these self-efficacy type of narratives? Maybe. So, this is just some of the ways I frame these things. I'm like, you know, you don't have they might not even test weak in their hips. This is another thing I see. It's like, oh, you know, your strength is pretty good there. It might not be a strength issue, but that doesn't mean going through these motions can't be helpful. Okay? So another one, same thing I do here, side lying hip abduction. So from here, go ahead and raise up. Okay. Good. Yeah, so that's what we see is, you know, the foot goes forward or the hips roll back. Whatever, everybody does it, but then I'm just teaching them how to change a little bit differently. Okay? Good. I call this the coronator motion. No, just kidding. Everybody does this already, right? You guys all know this stuff. There's nothing special about this. This is just a different way of doing it. Okay, so next let me have you sit up on the side again. Okay, so from here, we could do some nudging. It might, you know, neurodynamic motions are a great way to do some of this nudging stuff because you are, you know, the whole concept of kind of looking for tension and looking for some of these things that I talk about as being an edge are already kind of built into that. And so that's a nice way to do it. And you could do it from like a slump position. You could do a nudge if that's something that ends up being relevant to this motion. So stacking the deck. So here's another thing. Again, I tend to look for opposites. So if they tend to have pain with a motion that tends to be in one direction, I'm looking to go in the total opposite of that. So if they tend to have that pattern where their pain happens with knee in, foot out, okay, I'm going to go the opposite direction. I might take this where I might actually do a bit of hands-on stuff. I'm sorry, I'm going the wrong direction. I might push inward from the lower leg and outward from the upper leg. Okay, go ahead and push up. That looks like mulligan, but you're doing it wrong. I know. So, see, same idea. Okay, so that is a stacking the deck. Okay, so let me have you stand up and let's actually go over here so neither of us fall off the deck here. So again, let me have you do just a squat. Keep your heels down, just about halfway down. Okay, good. Yep, heels popped up. Right. Oh man, good patient. All right. So another thing I might do here is I'll put my hands on their outer knees and I'll say, go ahead and squat down a little bit, but don't let me push you in. Right. Push out against me. Good. Right. Same idea. Now do that without me pushing. Right. And which is the opposite of the way that they probably. We're looking for something in the opposition of the way that they move. If they have a tendency to go inward, I'm trying to teach them to go outward, which I'm not describing this in strain patterns and saying that you're tearing apart the inside of your knee or anything like this. I'm just saying we're moving differently from the way that you tend to move on your own. Okay, good. Actually, while you're still standing, I will show one scraping the barrel that I call it here, is just kind of a circular motion of the knee. And same idea. So go slow enough that you can kind of find where you want to kind of find that, again, whatever you consider to be that protective stuff, and then you just stay along that throughout the motion. If they have pain in lots of directions, some of these types of things can be useful. Okay, good. Okay, so let me have you take a seat here again. Okay, so let's jump ahead to It's one of the upper body. And on the handout, I've got something on there that has like positional and movement related and some of these things. It's a place for you to take notes. So when I'm looking for these opportunities, again, I'm kind of looking for tendencies. I'm looking for things that can be changed about the way that they just kind of tend to move on their own. And, a lot of times you'll see these things like people tend to move with their shoulders way down or whatever like that. Cool. I do the same thing. Tall people, the world's built kind of low for us. It's just kind of what happens to us over time of moving in a certain way given our surroundings. But if that's the case, and let's say now we're talking about someone who's got neck pain, okay, hurts to turn the head to one side, and let's also say it hurts when they lower their arm, right? This is another common thing that we see a lot. Ouch, on the way down, that kind of painful arc. Okay, so one thing I might do that is a positional approach to a novel movement, I might just bring up their shoulder blades a little bit. Okay, now try turning your head and see if it has an immediate effect on their motion, right? I call this the immediately effective novelty. And think in this terms of the comparable sign. I think it's Jeff Maitland's term is comparable sign. We're looking for a change that we make that immediately has an impact in the relevant motion, right? Because then we've got something that they can run with. Okay. You could also have them nudge the same way that we did before. You could turn your head to one side and find that edge, that place where whatever you consider to be that protective behavior starts, and you work right up to it. You could add diaphragmatic breathing here once again, right? Okay, good. Now, another scraping the barrel type one, a rotational one. What I want to have you do is you're just going to move your head in a circle like this, and you're not like this, almost like you've got a pencil coming straight up out of the top of your head and you're trying to draw a circle on the ceiling. And again, you want to kind of find where that edge is, and you're just going to kind of run along it as far as you can. Now, you can kind of start combining some things here too. With some of this circular stuff, they might be able to stay along the edge and they get to a point where it's like, that's kind of, let's say it's the shoulder. I've switched on you without explaining. I've gone to my shoulder now. Okay, and they go along the edge until they find a spot where it's like, they can't figure out a way. Then they can turn it around and they can kind of nudge from the front side and the back side, and eventually maybe they get all the way through it. Okay. Yeah, Jason was doing this great. There you go, Jason. Okay, good. So let's switch to the shoulder here real quick. Okay. This is a sensitive shoulder already. Are you okay with demonstrating with it?
Yes.
Okay. So let me have you raise your arm up. Okay, and then bring it back down, and they say, "Oh, it hurts when it hurt here," and they're kind of describing to me what they feel. So one thing I might do is I might help the shoulder blade through the motion here and see, did that make a difference? It makes a difference. Yeah, what do you know? Okay, so then I'll say to them, all I'm doing is I'm just kind of bringing your shoulder blade through the motion, maybe a little bit more than what you normally do, maybe with a little less effort. And then I'm going to get them on the wall, and I'm going to show them how to do this themselves. I'm going to teach them, bring your shoulder blade through. It looks just like movement impairment syndromes, but you're doing it wrong. Yes. Okay. So here's another one I like. So and Feldenkrais was all over this stuff. I was talking to a few folks last night that are in the Feldenkrais method. I mean, he talked about this stuff a lot. But one of the things that he talked about was this idea of reversals, right? Doing something in the opposite of the way that you did it before to change the context. So some of the ways I look at this, taking an open kinetic chain motion and making it a closed kinetic chain motion. All right, so since we don't have a good wall, I'm going to be your wall. Go ahead and stand up. So if it normally hurt for you to raise your arm or lower your arm, right, so you plant that hand on the wall and now squat. Okay, now it's become a closed kinetic chain motion, right? It's the same motion, the shoulder still flexing. Okay, so that's one way to do it. Another way is to take what was a concentric motion and make it, an eccentric motion. His relevant pain was lowering the arm, right? This was eccentric. Turn it into concentric motion, kind of push down into me like this. Good. Kind of in a bad position here. Push down into me. A lot of times they'll say, that feels better. Right? Okay, so you can talk about this from various directions of muscle activation and things like this, and I'm sure all that's happening, that's fine. But you could also look at it as they are, again, maybe activating a muscle in a way that is more normal. That's fine. I will talk about that. But also, it feels supported. They've got their hand on a wall. This is another thing when people are in crisis, that feeling of support, depending on where they're at on that okay scale, sometimes we need support. People do better. They've got family support and these types of things. There are narratives that are consistent with this. But again, we're also just changing the context. Sometimes we're just making guesses at what impact on the narrative it has, right? But that's the way I kind of want you guys to think about this. Okay, so I'll go ahead and sit back down on the plinth, because there's one I skipped on the knee I wanted to show you with reversals. Okay, so let's say it hurts when you extend your knee. All right, we're going back to this, skipping around. So reversals, changing something that was a concentric motion into an eccentric motion. Go ahead and let it bend again. Okay, now this time I'm going to pull forward on your foot, and I want you to let your foot come up again, but kind of give me a little bit of resistance, or let me give a little bit of resistance into you. Okay, so same thing. And then go ahead and let it out slowly. Okay, again, same motion, still extending the knee. We've just flipped it a little bit. Right? We've changed the context. Okay, good. So, again,
my hand up for eccentric hamstring.
Yes.
Active negative.
Yes. Yeah. Exactly. Yep. And some of the stuff I've put out there talks about it's more like active insufficiency. Is another term that's out there for it. You put the area of concern under in a position where it does not have great leverage, and then you ask it to do some work. That's I've got a wrist video out there that talks about this. I'll show this to you. So I'll have them extend their wrist, extend their elbow, and then extend their fingers like this. And this is one that I'll do for elbow pain. And then I'll have them do the same thing here, like this. And sometimes people will feel this kind of cramping, and then that's the active insufficiency part of it. But it's because it's an active insufficiency, this is the reason why I think it's important, because it is not a motion that we've got a great position of leverage on. It's not one that we are going to tend to do on our own very often. So you put them in that position, and it's the idea is that hopefully it becomes a novel motion. It's just not something that we're going to tend to expose ourselves to. Okay. Okay. Good. How am I doing on time, Jason? I'm still good. How much time do I have still? About 5 minutes. Okay. Good. So let's move on to. Got a little more time. Went faster than I thought. I've got extra time to play with here. This is nice. Oh, I know. So let's talk about manual therapy here a little bit. So let me have you go ahead and lay back down on your back again. So I told you I'd kind of talk you through some of the stories that I use. So one thing I think we got to be really careful with, there's a lot of manual therapists in the room, is, again, we want to foster self-efficacy. And there's always that chance with the laying on of hands that any gain is going to be assigned to us and not to them. And that's not what we want, right? We want them to feel like they got out of this problem of their own accord. We are more of a consultant, a port in the storm, I think is what Norton Hadler calls it. And John mentioned Norton Hadler, one of my favorites. If I've got actually a reading recommendation, I think, on my notes. But anyway, we got to be kind of careful with this. We don't want to steal their self-efficacy from them. So this is kind of one of the stories I'll tell in the cases that I do use it. I'll say, and Diane's probably, I don't know if Diane's going to demonstrate any of her stuff or not, but she has this great way of approaching a person, landing softly, real gradual shifts. And what I'll say is that whenever you encounter something new, your body's going through this kind of friend or foe process, right? And what you want to do is land and proceed in a way where you're trying to not engage, not become part of the foe narrative, right? So we land softly, we do things, set up, all these things. I mean, we're probably talking on specific effects here, right? But this is where I'll talk about the nervous system sometimes. I'll say, your nervous system is constantly sampling its environment, and that includes me. So all we're trying to do here is land in a way that it goes to this friend or foe question, which is consistent with the edge again, but do so in a way that the answer to the question is, okay, this is not something that we've got to be concerned about. And then hopefully as a result of that, we get some backing up of the protective response, the edge stuff. And immediately I go into test, retest type of situations. right? And hopefully I would never have gone, hopefully something that it would maybe help to keep from stealing a person's self-efficacy with manual therapy would be to have established some control over it by themselves before you go there, right? You already have shown that they can control this, or that they can go up to it and away from it with control on their own. And then this is just a facilitation. Okay, let's just see if we can get this moved along a little bit faster, but I'm going to be careful about when I introduce this and who I introduce it with. Okay? Good. So let's have you go ahead and sit up again. Let's do some stuff at the, oh, I'm sorry. Like, go ahead and lay back down again. Like I said, I've got extra time to play with here. I'm kind of excited about this. So this is another one. So go ahead. Getting close? Yep. Okay. Okay, we'll do this one more thing. Let me have you roll onto your side here. So 3 places that I look at as prime targets for novelty in a lot of people: ankle, hips, thoracic spine. For one thing, these are places that, for the most part, people tend to feel pretty comfortable with going in some new directions. And so one thing I'll do at the thoracic spine, a lot of times I'll have them bring knee up here. I'll actually stand in front of them so I can kind of block their knee and hold it up here, and then I'll just have them roll back, right, like this. And again, there might be an edge here, so we might say, okay, we're looking for the edge. But this might also be something I've gone away from the site of pain. And this is something that, depending on the status of the person you're working with, you might not want to go right at the place where they're having their symptoms. You might want to move from another place first. Okay, so a lot of people tend to be a little bit bound up in their rotation, which, whatever, that's cool. But it's also a place that's pretty easy to gain some rotation in a lot of people. So I'll have them work here, I'll have them do some diaphragmatic breathing, I might do some contract, relax, again, all with the same narrative things that we talked about before. And then I'll have them stand up. Go ahead and stand back up again. And I'll have them retry the baseline motion. Okay, good. All right, so I think I'm going to wrap it up there. I'm kind of starting to jump around a little bit, but go ahead and open up questions. Thank you very much.
I think you cured him.
Yeah.
Oh, I said cured. All right, so we've got some questions. I've got Mandy is going to be bringing the microphone up here, so we've got a question in the front row right away. I've got a couple more hands up, so Mandy, I'm going to have you come right up here, front row. And then we've got number 2 right over here. And the rest of you, queue up your questions. Also, if you have multiple questions, start with your most important one, because I have a feeling
Looking at you.
Simon might have poisoned the well for you.
Hi, I'm Raven Trevelyan. Thank you for the demonstration. Sure. I'm very motivated to get back to Seattle, and I specifically have a client in mind I want to try this out with. I'm concerned that I noticed you drew on some specific things that from a physical therapy knowledge base and from a psychology knowledge base. Not to sound too Rumsfeldian, but are there some unknown knowns why I shouldn't plunge right in with my massage therapist knowledge base and begin trying this? What should I be aware of to observe scope of practice and to keep the patient safe?
Sure. Yeah, that's a good question. So I would say, of course, we always want to rule out red flags. So this is kind of the step I skipped in my progression here, is going through the evaluation. At this point, I've taken a subjective history so that I could have hopefully ruled out any red flags or ruled in any possible contenders, and had a chance to do some special test and triage testing to see if any of those make it through that level, at which point if I find anything that I'm not confident about, I refer on. And I would think that just in general, referring anything on that potentially is not a non-specific pain problem, we might be needing to push that down the road. But when you're confident that you are dealing with a non-specific mechanical pain type issue, then the nice thing about this is because you are engaging the edge of that motion, and this is not something we treat fractures for, this is not, this is non-specific pain. Regional pain syndromes, Norton-Hadler. You engage the beginning of that process, you're not pushing people through boundaries, right? And so I think for that reason, we can do a lot of things conceptually with people without necessarily having them move a lot. And so I guess to answer your question, as far as getting people in and making sure you're staying clear of your boundaries, when in doubt, make sure you're you're not pushing a boundary that you're about. And let the patient lead this process. As far, again, we're working with their subjective space that we can't access, so we need to let them lead this process. We more are, again, setting up the context that they're working within. So does that answer your question? Okay. Okay. Thank you.
Thanks.
So we've got Eric. Eric is next, and I need another hand here. So, okay, we've got
Thanks, Cory. As someone who's spent a lot of time thinking about the overlap of movement and pain and attended all the Sarman courses, some of them twice, I think you've really captured movement and pain. This is my understanding with the literature very well, and it's been a game changer in terms of what I've done as a practice. My question is regarding one specific patient. Maybe this patient is, maybe describe him as experientially avoidant, because a lot of what you're trying to do is tying movement in with someone's experience and linking those two things together. And this might show up as sort of apathy, maybe, or just you get a sense that they're not following you. And maybe just talk about how you work with that as a clinician.
Sure. So, yeah, that's another really good question. So, one thing that I'm always shooting for, again, I want these things to be coming from them. I want them to feel like they've gotten better of their own accord. So I'm looking for any way I can that whatever change or whatever idea comes about, if I can figure out a way that it is their idea, or if we can set it up so that the change was their idea, that is always going to be better than something that has been dictated to them. So in those cases, and I can remember one case in particular where this happened. I was working with this person. I cut my teeth in the Sarman method too. Some of you may know that was kind of my, that was what I cut my teeth in as a PT. And so anyway, I had just spent 45 minutes talking to this person about moving their scapula and doing this and that, and we were on the wall, and I mean, I just was working like crazy to try to get something through that made sense to him. And all of a sudden he turns around and he says, "Oh, I feel, man, that was pretty awesome that I just figured that out, that I just came up with that." And my immediate instinct, my ego was like, I just spent 45 minutes showing you this thing, right? But I didn't say anything. Luckily, I was standing behind him, so he couldn't see me go, "What?" But it was kind of a flashbulb moment for me that, like, that is exactly what I wanted. That was the best thing he could have ever said. That is exactly the response that I wanted with him. So trying to set it up so that they can kind of explore motion and see a change and it be something that they've done themselves, which is not easy necessarily, but that's always good. Another thing too is starting with small samples. Like Cara was saying, sometimes you don't feel like you're making an impact and they come back later and turns out that you have. You can kind of chip away with some of this stuff. And sometimes you've got to meet them where they're at. It's not exactly, you don't have to go full bore into the entire explanation process from the beginning. Start with something simple. It might even be just talking to them about, maybe they've come in with a surgical procedure in mind and, their neighbor, something has had this and they're just looking for their chance to go and get their MRI so they can get this disc cut out of their back and what have you. Start simple, throw out some research. It's good to have some research in your back pocket that you can say, well, we know that the process tends to play out this way, whether you do this or whether you don't. And so these are some things that we can try. But those are difficult, and I by no means, I fail all the time, right? I fail with people all the time. Some people aren't ready to hear what information that you've got, and sometimes maybe you aren't the person to be telling the information. Some of those things you can't change. I can't change that I'm a man. Some people might hear it better from a female. There's lots of things like that out there.
Yeah, thanks a lot, Cory. I've actually been using your stuff in the clinic for about a year, made a handout and the whole deal. And I find the same thing. I struggle a lot with many people who have a really difficult time being body aware. Most of the patients I have widespread pain along with some other pretty severe surgical issues and failed back pain syndrome, that sort of thing. So trying to help them find the edge is my biggest challenge, because they tend to go way past it every single time, and it's obvious in their body language that they're doing so. And even when I point it out and try to use subtle manual cues and verbal cues, they still have a really hard time understanding even what I'm asking of them. I wonder if you could speak to maybe some more subtle techniques for
Sure.
these kinds of folks.
Yeah, so So a couple things. One, sometimes there are people who, they're like, I live on the edge. I'm at the edge right now, right? And so, like, every movement you've already crossed over. And I think some of the graded motor imagery stuff and some of even the, the mirror therapy stuff can be a nice way to even step back from this baseline. And you can go through the same concepts there. Another thing I would say is, again, if you go away from the site, so as far as helping a person figure out what the edge is, right? So one thing I like to, and everybody can try this if you like, if you put one hand out in front of yourself like this and you point your fingers down, and you just bring your hand out like this until you first notice tension, right? Yeah, bam. Sit next to somebody you like so they don't smack you in the face. Okay, once you get there, okay, that is an edge. This is hopefully, don't do this in a painful arm, but you do this somewhere else. And then, then you can say, okay, here's something I want you to try. Once you get there, pump that wrist 5 times at the edge. Okay, once you've done that now, do you still feel the same amount of tension? And a lot of people say, no, not so much. Okay, find the edge again. Okay, once you find it, again, go through 5 motions. Tension on, tension off. Okay, did it change? If so, you kind of keep. So that's a good way that I'll do this. I'll go somewhere else, and I'll show them in something that's simple and straightforward, and then I'll say, okay, now let's come back here. This is kind of what we're after. That's one way to do it. Yeah.
All right, we have. I'm afraid here, but all right. And we have.
I'll do one, though I have more. You just talked about red flags and refer out, and I'm thinking, we actually, when doing this, possibly creating an increased level of threat for the patient? Because most red flags are not validated. So we use these red flags as the truth, but when we test them, only very few are. So if we as manual therapists or massage therapists actually can decrease their pain, but we have a worry, shouldn't we try to decrease their pain and then say, listen, maybe you should talk to your doctor as well, just to be 100% sure?
Yeah.
Instead of, oh, shit, this is dangerous, there's a red flag, refer out.
Yeah, so I think of these things in levels to a certain degree. There are certain findings that you are not, this is a finding that is not appropriate for me to do anything with until you've cleared this out. If somebody's got a potential fracture, you need to get this figured out before I do anything with you. There are other things where, it is something more in terms of, this is something we need to keep an eye on, but this is not an emergency type of situation. And your treatment can kind of become a test for this. We can say, okay, we can run through some of these things, and if it's not going to help, we're going to know this pretty quickly. And I'll say to them, I'm going to want you to follow up with your doctor. I'm going to want you to follow up with me pretty quickly on this. But whether or not you've responded in the way that I'm expecting that you will that'll have some input into what my next recommendation for you is going to be. Or I'll say, go ahead and set up your appointment with your doc. But in the meantime, I want you to try a few of these things so that when you see him, you can tell him what's going on, but you can also tell him that you've tried some of these things and this is what the response has been, because that's going to be useful information for them. So there are different levels of concern with some of these findings. Again, open fractures, a potential non-mechanical problem, these types of things I'm not going to mess around with too much. But in the majority of the cases, we're more looking at somebody who's worried. This is the more common one I see. Someone who's worried that they maybe have a slip disc. I don't know. Yeah, I know. But that's what they come in worried about, right? So, maybe I've gone through my testing, and their pain, their subjective pain, it doesn't cross the knee, which automatically gives me an idea that, it's less likely already. I sit them on the table, straight leg raise is negative. Okay, and I can kind of walk them through. These are some tests that kind of give us an indication that were that a problem to begin with, to worry about, that it's probably not there. But if they're still concerned about it, first of all, I'll kind of walk them through what we know about it. But then again, I'll say, okay, well, why don't you try some of this stuff, and then let's talk again in 2 days, and let's see what you think then. In the meantime, seeing me is never an either-or proposition. Just because you're seeing me does not mean you can go see your doctor right out as soon as you walk out of the door. If you feel like you need to do that, then go do that. But here are some things you can try in the meantime.
We have time for just one more.
Hi, Stephanie. Dosing,
Hey, Stephanie.
is once enough?
One visit?
One application of these novel movements, for example.
It depends. Yes, maybe. So I didn't go into this. My other favorite thing to talk about is the method of how I deliver care. I work in the workplace, so I go to people's places of work, and that's where I work, and it's a whole different atmosphere, and it's great in a lot of ways. But because of that, a lot of the people I see are pretty early in the process. They can come in and see me whenever they want. And so a lot of times what we did up here is it. I mean, we do that. They've had a chance to get their questions answered. The big scary things, we've talked through them and kind of reasoned why that's probably not the case. We've established some things of ways that they can control it and shown them some ways to get moving again. And, okay, and then maybe we check back in and they say, nope, good. That they're right on that natural course history. And so sometimes that's the case. But in other cases, when, and I put as the goal, like if I back up to that slide, I put that goal as sometimes we're preserving self-efficacy. And those folks, pretty quick a lot of times. Sometimes we're building self-efficacy. Sometimes that takes a little bit longer. But there are other folks who it's almost like an absence of self-efficacy. It's the opposite. It's dependence. And in those folks, those things don't tend to change real super quick. And so, they might need us around a little bit more. But there are definitely, in my case, because of the way I get to see people, there are a lot of times where I only see somebody one time, and I say, give me a holler if you have any more trouble. Yeah.
Thank you very much.
Yeah, thank you.
So we have time for a short break.